All right, hey everybody. So we're nearing the end of our ENT block, and I know we've had the sort of didactic overview on thyroid. And so hopefully this more interactive virtual microscopy on thyroid will answer some of your questions, feed you some more information. I've stuck with sort of common things, basic things, need to know things. I'm not getting into the weeds here with, super rare variants and stuff. We could certainly do that at another lecture. But this is sort of more like, hey, here's what we talked about as an introduction. And here are some examples of those things, in more depth. So unless anyone has questions, I will begin. I hope that you've all had a chance to look at these. I don't expect, that you always 100% have the answer, but at least please participate with descriptions and some differential diagnoses, et cetera. So hopefully you can all see my Path Presenter screen. Let me just maximize it. Cool. So, yeah.
Yeah, we can see it.
Cool. So the first thing I put was just normal thyroid histology, because I know that sometimes we don't really focus on that. And for thyroid, a lot of what we call microfollicular or macrofollicular or lesional is going to depend on how it compares to normal, right? And so I just want to review briefly normal. As we know, there are both C cells and thyroid follicular epithelial cells that compose the thyroid, but of course the follicles are the most prominent in number, and you don't really see the C cells on normal H&E unless they're hyperplastic. And so we're not going to really maybe see the C cells in this normal thyroid, but we can certainly see the normal follicular cells. And so what you see is there's generally a kind of homogeneity to the size and even shape of the follicles. They're sort of uniform and sort of medium or moderate in size. And so that will be our kind of comparison point for when we call something micro and macrofollicular. Here you can see that the nuclei are, of the cells are sort of cuboidal, right? The nuclei are lined up kind of in the center of each of the cells. They're very round. The chromatin is very finely granular. So compared to some of the PTC nuclei, these are actually sort of, dark, right, or blue. They sometimes have tiny little nucleoli. All right, cool. And they contain in the middle of colloid, of course. So who knows what these characteristic crystals are that we may see within the center of the colloid?
Oxalate, calcium oxalate.
Calcium oxalate, exactly. So the presence of calcium oxalate is pretty specific for thyroids. And so I don't really have a histologic example, but when you're dealing with like maybe a frozen or something where you can't tell if it's thyroid or like cystically dilated parathyroid, you may want to check around for the calcium oxalate crystals. So that's that. This has many kind of nice examples of those. So this is normal thyroid, just for your comparison. There was really nothing else on this slide. There was a little lymphoid kind of aggregate with thyroid follicles in it on this slide. So does anybody want to take a gander maybe at how to interpret this focus right here? I forgot it was there, but hey, since we see it, let's talk about it.
Is this lymph node?
Is it what?
This is lymph node?
That's the question.
I mean,
that's what I'm asking you.
Presence of, as I know, presence of thyroid tissue in the lymph node is abnormal.
Mm-hmm. Okay, presence of thyroid tissue in lymph node is abnormal. Is this a lymph node?
No, maybe it's just like lymph collections, or I'm not seeing capsule, I'm not seeing lymphoid follicles.
Mm-hmm.
So this is not lymph node.
Yeah, so I think we have to be, anybody else?
I was just going to make the same comments. The usual features for lymph node, you'd expect to see a capsule. Sometimes you can make out sort of an oblong or sorry, someone else.
So I would say this is not lymph node because there's no capsule, there is no sinus histiocytes, and I mean something this tiny, you wouldn't expect to see any germinal centers, if especially if it's not like a reactive one. But it kind of lacks capsule and sinus histiocytes.
Yeah, so I think we just my point here is we have to be kind of cautious with lymphoid areas near and around the thyroid. Here's another one that's a little more a follicle rich and lymphoid poor, but still has a combination of follicles and lymphocytes. And so it's sometimes these I just point this out because this is going to happen where like a surgeon plucks out a little one of these lymphoid nodules that they don't know what it is. Is it thyroid? Is it parathyroid? Is it a lymph node? And they send it to you and they say, and you see a lymphoid aggregate with thyroid follicles in it. And so the differential diagnosis, right, is metastatic carcinoma in a lymph node or just a plucked off isolated lymphoid aggregate with that happens to have thyroid follicles in it because the thyroid has some inflammation, right? These are called like parasitic or exophytic nodules. I didn't specifically put that slide on here for this, but here's an example of it. And it's you're going to see it in practice and you're potentially going to see it at the time of frozen. It more commonly happens in like Hashimoto's thyroiditis where there's tons of inflammation and these little nodules kind of pop off. They like auto amputate themselves. But okay, good, just to think about. All right, number 2, it's called exophytic or parasitic nodule sometimes. The nodule of lymphocytes with thyroid follicles doesn't have a name, but that process of kind of amputation of those little foci is called exophytic or parasitic. All right, so some of you last time we talked about thyroid core biopsy, and some of you asked about like why it's challenging or how often do we get it. So here's a very recent example of a core biopsy we got from our famous hospital in Valparaiso, Indiana, that does these. And so I wanted to show you an example of the core and then what the follow-up was on histology. And so does anybody want to take a gander at sort of describing what they see on this core and what their differential diagnosis might be or what they want to communicate to the clinicians based on our knowledge of like thyroid FNA as the model of thyroid biopsy?
So I didn't look at this beforehand. And looking at this, it looks very crushed. You don't see in like this little snippet, you see like some normal-ish tiny micro follicles. And you do seem to have a lot of background colloid that's just like smushed in and like, I mean, looking at this, I have to go on higher power to look at nuclear features, but like this, I would say is probably some sort of smush microfollicular adenomatous nodule. On higher power, oh God, there does seem to be some irregularities in the nuclei. There. So someone, Ryan says pseudo inclusions. They could be pseudo inclusions, yes, but it also, I feel like there is areas where there looks like to be overlapping, but at the same time, it doesn't look like it's what's the term? Like they're not smushed together. It seems like they're just forced onto each other.
Crowded? Is that what you were thinking, Cindy? Crowding?
Yeah. Like molding, nuclear molding. It doesn't look like one is like curved onto another because of that. It looks more like, I don't know, artifact where like these nice round nuclei are just like overlapping each other. I don't see any nuclear grooves. Honestly, I'm a little concerned. But at the same time, it's like it looks so badly preserved.
It's so bad. It's so badly preserved. Yeah, it's terrible. So okay, so what do you want? What do you want to tell what are you going to diagnose to your clinicians? And if you model it, we've tried on core biopsies to sort of model it after the Bethesda system because that's what they're used to, right? So they're used to like 1, non-diagnostic, 2, benign, 3, AUS plus, 4, follicular neoplasm, 5, suspicious for malignant, 6, malignant. Where does it go for you?
God, like a suspicious? No, not that's too high. Like
So it's got, I'm just gonna summarize and you guys think. So it's got, it seems to be lesional, right? This doesn't look like normal thyroid like we saw in the last case. There is maybe an edge, maybe a capsule, either a capsule of the gland or a capsule of the, the nodule probably. Here's another edge, right, where there's kind of a little, maybe a little capsule. It is composed essentially of follicles, right? Micro follicles, small follicles. I don't really see good papillae. I don't really see solid growth. In between the follicles, sometimes there's a little bit of this stromal expansion. And so I'm not sure if this was what you were commenting on as colloid, but I think the colloid is restricted to the center of the follicles, like this darker pink stuff. And I think that there's a little bit of stromal edema or stromal expansion between the follicles, resulting in this like more pale pink stuff. So it's microfollicular. It's got like super weird nuclei. But if you, I don't know who of you was at my talk on Friday, the virtual path grand rounds thing, but like your question of pseudo inclusions or pseudo inclusions is a good one, right? Because you look at these and you're like, wow, those are kind of punched out looking holes in each of the nuclei, but they're like in every single nuclei, and they're like all the same kind of shape and size and character. And so what I don't see, right, is like an obvious patch of cytoplasm within this hole. It just looks like a paler blue than the nucleus, but it doesn't look pink like the cytoplasm, right? And it's in every cell. And so this to me is more indicative of a pseudo inclusion or an artifactual vacuole. And this is exactly the problem on these core biopsies, because this finding is so common. This is even an H&E slide from an outside. This is our in-house H&E stain from the outside block. So even doing our stain on the tissue didn't really help it. So now where are you going to give this? Does this need to come out? Are you like, this is benign? Or is it malignant, or is it indeterminate?
I feel like it's indeterminate. I would recommend they do like a normal FNA.
Mm-hmm. Yeah, unfortunately they don't. They send these to us and they want us to tell them it's indeterminate so they can take it out, which is basically what we did. So we called it a follicular, suspicious for follicular neoplasm / follicular lesion of undetermined significance. Yeah, you could do a ubiquitin stain. And actually it's funny you mentioned that, because I did do it on the resection. I think it's still cooking in IHC. So this is the resection. You can see that it's like super well circumscribed. You can see that there's background kind of inflammation, okay, and some cellularity of the background follicles. But you can obviously tell that this is, this is a discrete lesion separate from the background. Cool. It's well circumscribed, great. It's composed of follicles, great. It's got that background stromal edema that we saw in the biopsy, great. And now what do the nuclei look like?
Now the nuclei look very happy.
They certainly don't have those weird artifactual vacuoles.
Yeah, papillary-like nuclear feature. We have some papillary-like nuclear feature here. We have overlapping, we have clearing. They are different than the surroundings and outside. We have some papillary-like features here.
Yeah, so I think the nuclei aren't completely cleared on resection. Not cleared, but they're actually cleared, but they're not cleared. They have nuclear clear ring or chromatin clear ring. We haven't eliminated all of the weird nuclear features, is what I'm trying to say on the permanent, right? So you could consider a diagnosis like NIPT-P, right? Non-invasive follicular thyroid neoplasm with, okay, papillary-like nuclear features, because they're kind of enlarged and they're kind of cleared. But I think we can all probably agree that we shouldn't call this cancer. It's not invasive. It's very well circumscribed. It's totally follicles. Okay. So, we called the biopsy, I think, follicular lesion with nuclear atypia, see comment. And then we called this, basically follicular adenoma with nuclear atypia. But what else is going on in the background? And this is nice for comparison.
Invasion. we have, I believe here we have invasion, right? Here. Yes.
Is
Either
it
one.
is it invasion or just like a little discrete focus of like papillary?
Maybe, no, we have papillary. We have papillary. It's invasion.
Right, but oh.
Go ahead, Perry.
Oh wait, I mean it's not necessarily invading, right? It's just like a little discrete focus. But it's not invading another structure, right? It's not invading like, or maybe I'm just confused.
Is it invading the thyroid gland? Is perhaps what Reham is trying to say.
Okay, sorry, I misunderstood. I thought it was invading a different structure and I was puzzled.
Ah, got it. So is it the same as this?
No.
No, right? It's different. It has stromal fibrosis. It has architectural papillae. There's some nice papillae cut in cross section. And it has very wrinkled, grooved, folded, overlapped, cleared nuclei with, I think when she says invasion, she means that this focus is not well circumscribed. It is showing invasion into the adjacent thyroid parenchyma as defined by, sorry about the calcification here, as defined by stromal fibrosis. And therefore it is malignant, right? Like, so not only is it malignant based on its pattern of invasion into the thyroid, but it's malignant based on it having papillae and good nuclei. All right, so this was just an example of, well, the thing that they were going after ended up being essentially a benign, adenomatous NIF-P kind of nodule. There's chronic thyroiditis in the background, but always don't forget to look out for incidental microcarcinomas. And if you ever have an incidental microcarcinoma, you can compare what you see in the incidental carcinoma to what you see in the lesion of interest, and it sometimes may help you, be like, oh, this is completely different. Like, I feel good about my diagnosis. Like, this carcinoma is obviously not that, right? So I feel comfortable calling this basically benign. Does that make sense? Okay. So the challenge of thyroid. So next one. Do you see a lesion?
I'll take a crack at this one. So we've got, let's see here, a resection. It looks like there's some sort of capsule around. We've got macro and microfollicular nodule areas. And so if we look maybe more closely into the more like, I guess, quasi hypercellular areas, I mean, just because maybe there's more microfollicular nodules. Let's see here, what's going on. I also did not preview these, but I guess like in terms of nuclei, they look about pretty uniform. I'm not seeing like the same like grooves or atypia from the PTC nuclei that we were observing earlier. So, there's like a little bit of scalloping here. In this case,
just for the juniors, can you define scalloping?
Yeah, so let me see if we can find it. Yeah, here, so it's like when the colloid, it looks like the edges look like, I don't know if it like the scallop pattern in like clothing around, let's see if I can.
How about a scallop shell?
Like, or yeah, a scallop.
How about the
shell
scallop
too?
pattern of a scallop?
Something a little more easy to visualize. And I think that is part of like, is it like Hashimoto's or something like that? Oh, potatoes. Oh, yeah. I guess like no, not like potatoes. I'm not thinking, not like scalloped potatoes, but
like those
anyway,
like are all of the magazines now around Thanksgiving are talking about these Hasselbach potatoes or whatever, right? Where they're like, yep. They're like cut like this, and they are kind of like scalloped. Anyway, yeah, so it's resorption of colloid at the periphery of the follicle. It's basically an indication of follicular activity. So yes, you can often see it in Graves' disease because Graves is hyperactive, right? But you can also just see this active resorption of colloid in any active follicle. And so it's these holes that cause that edge, the scallop border. All right. Or the Hasselbach potato border, whatever you want to call it. Okay. So yeah, so your diagnosis is?
It looks like this is close, yeah, Graves' disease, but we don't, call that outright on resection because that's more of a clinical diagnosis.
So does Graves' disease diffusely involve the whole thyroid or not?
I don't remember actually. I think it
Is
does.
Graves' disease
Yes.
a tumor or a medical disease? Let's start.
It's a medical disease. It is a medical disease, so it involves the entire thyroid.
Right. So it's a serologic problem, basically, right? So you should have diffuse involvement of the entire thyroid of whatever it is. Does this diffusely involve the whole thyroid?
It looks like no, because there's a little bit of normal thyroid at the edge here. So, then that kind of scraps over the Graves theory. And yeah, so it looks like this is some sort of encapsulated, maybe follicular adenoma. It's kind of what I'm leaning towards right now. Because like we have that scrap of normal thyroid, it looks like we have some sort of capsule. It's got a ton of like microfollicular nodule, microfollicular areas too. So I'm, like looking at the capsule here, I don't know if I see anything invasive, but this is just one portion of however large this nodule is.
Right.
So I guess I will say follicular adenoma pending remainder of capsule.
Sure. Perfect. Great. Right. So, you always have to be aware of, does the thing that you're looking at, involve the whole thyroid diffusely? Does it infiltrate the whole thyroid diffusely, or does it sort of push aside the whole the thyroid, right? In this case, it pushes aside the thyroid, and you have this little rim of normal separated by a capsule. The other thing I'll point out to you is, thyroid follicular epithelial cells can uptake hemosiderin, and so see this brown pigment in the follicular cells? That's like normal. That can happen. So don't let that bother you for any particular diagnosis. That just can happen in normal thyroid. What I will point out though, in the background, is that there are these occasional like pokey, like papillae that are trying to poke into some of these larger follicular lumina. I'm just going to point them out as not only papillary carcinoma has papillae, these nuclei are obviously super bland. So just pointing that out, because this becomes important when we are trying to make a diagnosis between benign and malignant sometimes. But you can see these little pokey papillary structures in totally benign adenomatous nodules. Okay. All right. The next one, I think I can go over pretty quickly. We see that it also has kind of a rim of normal. It's also very cellular. It's also composed of scalloping and seashell. Thank you. Of microfollicles. Sometimes the microfollicles are compressed so much that the colloid is like just a tiny little pinpoint lumen. But what I wanted you to notice was the cytologic features of these cells. So how is this nodule different from the one we just saw?
It's much more solid.
Mm-hmm.
The cells themselves, there's a lot more kind of eosinophilic granular cytoplasm.
Mm-hmm.
The nuclei are pretty uniformly round with pinpoint nucleoli that are pretty prominent even at low power.
So if they're prominent, then they're not pinpoint.
Oh, sorry, that's, yes. People are saying more crowded, Magna says more crowded and dark, which, yeah, from low power would go along with kind of the more solid appearance.
And Tanner says Hurthel
cell, which first thing we would think of with all this kind of eosinophilic granular cytoplasm.
Yeah. So what's your diagnosis in this case?
So it looks like it's well circumscribed from what I can, from the section that we have. So like a Hurthel cell adenoma.
Yeah. So we talked, I think, a little bit about oncocytes or Hurthel cells, right? So Hurthel cells of the, follicular adenoma Hurthel cell type. So Hurthel cells are oncocytes of the thyroid, right? You can get oncocytes in any organ. Oncocytes have abundant granular eosinophilic cytoplasm because they are full of mitochondria. They have large nuclei with arguably prominent nucleoli because they are very metabolically active. So they're making a lot of proteins, et cetera. Right. And so when you see oncocytes in the thyroid, you can call them Hurthel cell, just don't call them Hurthel cell outside the thyroid. And it's now being conceptualized that Hurthel cell neoplasms, yes, are basically very similar to follicular neoplasms, follicular adenomas in this case. But some oncocytic or Hürthle cell neoplasms are showing also different genetics from follicular adenomas, like they have mitochondrial DNA mutations, right? And they're so slightly shifted over from follicular adenomas, but generally conceptualized biologically in a similar spectrum as follicular neoplasms, right? So Hürthle cell adenoma, follicular adenoma, you know, Hürthle cell carcinoma, follicular carcinoma, even poorly differentiated carcinoma, you can apply the same criteria when using Hürthle cell lesions. So this, you know, this does have some solid or trabecular growth, but it's otherwise, you know, no necrosis, no mitosis, completely encapsulated. I think we're good to call it benign. So good job on that one. Oh, this one, honestly, so does anybody have questions so far? This is another example. I put it in here. This was the same one I showed at that other conference, but basically, again, it's sort of a very circumscribed lesion. You can see, you know, normal thyroid doesn't, you know, bulge out on all sides. So if you're thinking, is this normal thyroid or is this part of a lesion? You know, imagine the shape of a normal thyroid, right, which wraps around the trachea. And so it has usually like a, you know, like a little C shape, right? And so your slice usually looks kind of like this, as opposed to this, which is bulbous, right? And you can see that there's a little rim of probably normal thyroid out here on the left. And so the reason I'm showing this one is because it's got, you know, kind of moderate to large size follicles. There are these small areas of a little more increased cellularity, and in those areas of increased cellularity, again, you get nuclear overlap and clearing and enlargement. And so this was just another one of the examples of those. You know, otherwise it's a benign follicular adenoma, you know, or adenomatous nodule, but it's got some papillary-like nuclei, so you can, you know, you can be okay if you wanted to call it a NIPT-P. I don't know how many of you follow the old literature, but, you know, Rosai wrote this paper many years ago about the quote unquote sprinkling sign. And so if you look on low power, right, you can see that there are kind of hypercellular areas sprinkled within, right? And so this sprinkling sign was thought to be a signal of the follicular variant of papillary carcinoma, which, you know, now in this case would be a NIPT-P, right? So I think that's interesting. You know, he was right. Like there is this like weird like sprinkling, but it's no longer a sign of carcinoma. It's just a sign of, hey, go look at those nuclei. Maybe you want to call it a NIPT-P. Okay. Oh, this is a great one. So who wants to take this one?
I can go over it. I just actually opened the slide. So it seems like it's a nodule, and then we have a resection margin. So I felt like there would be some residual thyroid towards the margin, and then we have this nodule, and then I'll just like go a little bit around the capsule to see if it's like well confined or not. I don't see that much of like the follicular pattern that we were seeing before in all of our follicular adenomas. It looks more pink, and it has like kind of lobulated, but like it is giving me a hyalinized appearance. And then but it's also like not jumping out as like, oh, I'm concerning about the nuclear features too much. The nuclei appears uniform, but some of them have kind of like maybe they have nucleoli, but I see I don't see very prominent papillary nuclear features.
Are you looking at my slide or your slide?
Oh, I'm looking at your slide now. Sorry, I just started going over the slide that was open. So we do.
Oh, it's okay. You should drive it yourself. But I'm trying to.
No, I mean it's okay. So there is like some of them have a little bit grooving. Now I see them have like inclusion kind of. There one or two have like, yeah, these I see pseudo inclusions. And well, on lower power, I was having a hyalinized kind of like nodule, but
Mhm.
it looks, it has like papillary features,
Mhm.
but it is well confined.
Mhm.
We don't see, I haven't even seen one mitosis, but if I'll fish, maybe I'll see a couple. But it's well confined. It's papillary. So
So good. So let's pause there. So it's very well
mhm.
circumscribed. I agree. I was just going to check out this little focus out here to see if this was invasion, but no, I think this is
Yeah,
something different. Okay. So it's very well circumscribed. It's composed of maybe some occasional follicles, but mostly these trabeculae, right? These sort of
yeah.
cords or trabeculae. And the cords or trabeculae are separated by this hyalinized stromal material. Excellent. And the nuclei are kind of grooved, kind of elongated, and have like what appear to be pseudo-inclusions, right? Like I think
Yeah.
the centers of these are eosinophilic, just like the cytoplasm. They are in only occasional nuclei. Oh, there's one. They're in only occasional nuclei. They're not in all of them. So it's probably not an artifact, right? And so how are we going to put all of this together into a diagnosis?
So I mean, if you don't laugh at me, so I thought of it as a hyalinizing trabecular tumor.
Yeah. Yes.
Okay. Okay.
Why would I laugh?
No, I mean, like the lower power just like
Mhm.
gave me that impression that
Mhm.
it's something that's very hyalinized, and that's like the only differential that came into my head at that
Yeah.
time. So
So right. So it's not, it's a great, that is the diagnosis, hyalinizing trabecular tumor. You know, remember you can have stromal, where was it? In one of these cases, you could have like stromal, you know, expansion between the follicles like this, right? But the other features, the other patterns of the follicular cells don't match for the concept of hyalinizing trabecular tumor, right? So you can get stromal material in other tumors, but to get the diagnosis of hyalinizing trabecular tumor, you have to have all these features. So what is hyalinizing trabecular tumor? Does anybody want to explain what it is and why we separate it out from other neoplasms? Is it benign? Is it malignant?
it's
Is it
benign.
PTC? Is it not? Yeah, so it's called tumor because it generally behaves in a benign fashion. As you can see, it's very circumscribed. It doesn't usually have lymph node metastases, but it has super characteristic PTC-like nuclei with pseudo-inclusions, and this very characteristic, almost like Zellballen, like trabecular pattern, where the stroma is expanded by this hyaline material. And so it used to be called, some people don't buy it and call it the hyalinizing trabecular variant of papillary carcinoma because of the nuclei. Other people say, dude, this is maybe a variant of papillary carcinoma, but it like hardly ever metastasizes if it presents with this morphology. So we're just going to call it tumor so as to not call it benign or malignant. In the past, it used to be called hyalinizing trabecular adenoma, but because some people say, oh no, it could rarely metastasize, then it was changed to hyalinizing trabecular tumor, right? So just like NIFT-P, hyalinizing trabecular tumor is one of these indeterminate malignant potential diagnoses where you neither call it adenoma nor carcinoma, you call it neoplasm or tumor, because you are like 99% certain it's not going to metastasize, but you're covering, you know, CYA and pathology, right? Like that 1% chance that it might metastasize. So this is a great example of a hyalinizing trabecular tumor. Okay. Okay. Comments, questions? All right. Next one. Oh, I think the hyalinizing trabecular tumors have not BRAF mutations. They have maybe RET PTC rearrangements, some of them. So they don't sort with like the very classic PTCs, right? They don't have the BRAF. They have the variant fusions. All right. What brave soul? Who hasn't spoken yet? just drive it and you think about it.
Just sort of tuning back in here right now, but I'm seeing these long tendrils of very dense fibrosis.
Mm-hmm. Does that concern you on low power?
I mean, it's, in other contexts, certainly it would, yes. In terms of like having sort of invasive lesion, but no, I don't actually see anything here that would clearly call neoplastic. If I think back to my old medical school days about what are the other sorts of medical thyroid disorders that could present this way, well, there is a subtype of thyroiditis, which is called Riedel or fibrosing thyroiditis. This is not as impressive as I would expect for that, though. Yeah, usually when you hear about that, you think about an entire thyroid lobe being knocked out. So,
no, you're right. You're right. So for fibrosing thyroiditis, again, it's a medical disease, right? So you'd essentially expect a diffuse involvement, okay? Yeah. But we have a focus of sclerosis within kind of this vaguely nodular background.
So has this person had prior instrumentation here before by any chance?
No.
This is what
not in this focus.
Sure. You know, if you were talking about biopsy, this is exactly the appearance you would have of a biopsy site change.
Yeah.
I mean, the cytomorphology of the cells, like in between the tendrils of fibrosis, are they have papillary nuclear features. The architecture I'm kind of hard pressed to describe here. Raham says in chat, could this be frankly PTC, and could this all just be a desmoplastic response? Seems not unreasonable, especially given now the more obvious nuclear cytomorphology you're putting in front of me.
So maybe it's kind of cords, yeah, kind of cords. Yeah. Cords of cells with, you know, kind of wispy cytoplasm, large nuclei, prominent nucleoli in this densely sclerotic background. And so if you think it's a scar from a prior procedure, of course, check, you know, but there hasn't been anything here. Also compare to the surrounding, right? So if arguably fibrosis in thyroid can give you some nuclear atypia. So always be cautious around areas of fibrosis to see what kind of nuclear atypia those cells have, whether it's reactive or potentially PTC. And so sometimes it's a subtle finding, I don't know, difference. So if we look in the normal, you know, this is what the nuclei of the normal-ish thyroid look like. They're kind of round, they're a little bit pushed together. And then we move into, this area of fibrosis, and then you start to see maybe a shift where you start to see a little more abundant pink cytoplasm. Don't forget about the cytoplasm. And you see these pretty open nuclei, which, you know, are they similar to that? Are they different? Well, keep looking and always be suspect of nodules that have this kind of scar-like pattern. So Riham has made the diagnosis on the chat of PTC. And so if you're uncertain, what's one thing you could do to maybe confirm your suspicion? So I'm very worried about this because it's scar-like on low power. This is not in an area of prior biopsy. It has these cords that infiltrate the scar, right, in all different directions. And the cytoplasm is sort of abundant, and the nuclei are certainly, you know, PTC-like. Always don't forget about, as I said, don't forget about the cytoplasm in PTC because it tends to be more voluminous than normal. Actually, that might be an inclusion right there. But what is something we can do?
Well, the entire chat just blew up with that BRAF IHC.
Yes, and you probably saw it on the next slide. No, I'm just kidding. So well done. So Heather, Tanner, Perry, excellent. So this is our BRAF immunostain. I think I saw an inclusion elsewhere. Yeah, you probably did. You probably did. If we looked hard enough across the whole tumor, I'm sure we would see an inclusion, but this is BRAF, and how do you interpret it?
This is enough.
This is enough. This is great. So look how far this tumor spreads, actually. It's sending tendrils right out into this, a blush is good. It's sending tendrils out into the normal thyroid. It's sending foci up here and out here. So when BRAF works, and it works well, boy, is it striking, because it will highlight every single tumor cell, and you can see how far this thing stretches, which maybe is farther than you initially even thought, right? So number one, it confirms the diagnosis, and number two, it confirms the stretching of it. And so if we look, now let's go back. I know it's flipped the opposite, direction, but let's go back and look in those tendrils, and maybe now you can follow them and see, oh, like maybe even some of these nests are cancer that were lighting up in those kind of fibrous tendrils. So I think this is a good example of a scar-like or a kind of a sclerosing papillary thyroid carcinoma that can be very subtle. In this case, BRAF worked very nicely. It may not work in all cases because only 80–85% are positive. So hopefully that helped. Do you guys have questions?
What would you if it wasn't positive?
I would still call it cancer. To me, there's no reason why this type of scar would look like this in a benign thyroid with just diffuse infiltration of the scar by these nests with arguably reasonably atypical nuclei. And so if you have a real scar of thyroid that's not PTC, usually it's more collagenous at the center, and when it spindles or like fingers out at the edges, you see a little bit of atypia at those edges around the scar, but there's not this much like cellularity in it, right? So this cellularity in the scar is worrisome. And yes, it's basically a desmoplastic stromal response to carcinoma. So overall, all of the architectural and cytologic features to me say that this is carcinoma, regardless of whether the BRAF is positive. In this case, it happened to be. And if Tanner can find his inclusion and send it to us, that would be, oh, that might be one. That might be one. They're a little bit not great on this slide. But yes, I would call this, there's one. I would call this carcinoma regardless. So here's an inclusion. So pink cytoplasm, nuclear membrane, blue chromatin, nuclear membrane, pink cytoplasm. Look hard for those inclusions if you need to convince yourself. Okay. Next. Well, the dots tell you the answer. Just
Little things poking out from the capsule there.
Something's poking out from the capsule. So, without belaboring the concept, now we're jumping back to follicular neoplasm. Sorry about the disorganization, but this is a thyroid nodule, right? That has a capsule that has a perfect poke or mushroom through the capsule. So capsular irregularity versus invasion. So sometimes when you are unsure whether something is capsular irregularity or invasion, there are a few things to take into account. One is, kind of draw with your mind or an annotation tool the contour of the nodule and determine whether you think these areas are inside or outside the contour of the nodule. Say, okay, exactly, right? So if you go blip and blip and blip, if you're drawing all these blips, that's a worrisome sign, right? Thank you for that annotation. And if you see these blips with intervening normal, like capsular irregularity shouldn't necessarily have intervening normal on either side of it. And so this seems to be on the other side of the capsule, which pushing out normal. These guys, I know it can be challenging, but there's an intervening, like, unfortunately, this isn't normal thyroid follicles. These look like vessels, but sometimes you could see like normal intervening follicles in these areas between the blips. That to me means these are punched out into normal, and normal is like being invaded in between these blips. So yeah, so I think this is real invasion. So what real capsular invasion? So then our diagnosis is right at the bottom, another mushroom. Yeah, exactly. There's one here, there's one here. So hopefully everyone can diagnose this as
Follicular carcinoma.
Pardon?
Oh, follicular carcinoma.
Follicular carcinoma, yeah. And so then the only other question is, exactly, right? So you see these very dense eosinophilic cytoplasm, granular with large nuclei. So you might want to think that this could be an oncocytic or a Hürthle cell carcinoma. And so again, the same criteria we use for follicular neoplasms, for follicular carcinomas, we use for Hürthle cell neoplasms. And in fact, in this case, you see a lot of that really, really bright pink cytoplasm. And maybe the nucleoli here aren't quite as prominent as we saw in the other case, but they're occasionally there. So you may want to render this as a Hürthle cell carcinoma, or follicular carcinoma, Hürthle cell variant, whatever terminology you take. But yes, I agree. I think that there's enough diffuse oncocytic change here that Hürthle cell carcinoma is probably a good answer. Excellent. So what I might not call capsular invasion is like on the other side, where you have little pokes into the capsule, but it doesn't end up on the other side. Now you have something that looks, ooh, like maybe that's lesional, and it's on the other side of the capsule. So this could be, right, the overhanging cap of a mushroom where you're just not seeing the stalk, right? So always look carefully for these foci outside the capsule, because this is also an indication of capsular invasion. If it's just poking in, no. But if it's out on the other side, yes. What else? This kind of poking in and like trickling longitudinally through the capsule, no. All right, so there are some foci of not true capsular invasion on this slide, like these longitudinal shapes, but there are some true foci, or some foci of true capsular invasion, okay? And then what is the next thing we always look for?
Oh, lymphovascular
LVI.
invasion.
Angioinvasion, right? And so in thyroid, I'll just point out that lymphatic invasion is different from angioinvasion, and you should always designate which one you see, because it's behaviorally predictive. Here's just another example of a diffusely infiltrative, again, Hürthle cell carcinoma, that I wanted to show you the difference. You know, sometimes you're dealing with a nodule like this, where you have to look very carefully at the capsule. And sometimes you're dealing with something like this, that just on low power already is like, oh, that looks like it's blowing through the thyroid, right? So there's multiple nests. These nests have intervening normal between them, right? So probably your epicenter was this, and you have totally, invaded through the capsule. What you see here are these very coarse calcifications in the capsule that we sometimes call, that they see radiographically as so-called eggshell calcifications. You can see eggshell calcifications in benign things, in malignant things. So don't let that give you a diagnosis, but at least let yourself know that there probably is a capsule here with calcifications, and just evaluate that capsule thoroughly if you see those. So this is another oncocytic or Hürthle cell carcinoma that has diffuse now I would call this intrathyroidal invasion. So yes, there's capsular invasion. Maybe there's angioinvasion. I haven't looked for it yet, but this is the pattern that I would call intrathyroidal, kind of more diffuse pattern invasion as well, okay? Okay. I think I'm just providing you more examples of suspicious follicular neoplasms and how to interpret them. 851. So I'll let you guys look at these on your own, because I don't think there's going to be anything extremely new in these next few slides, except for this. So these are lymph nodes that were resected along with this lesion here.
Looks positive.
Looks positive. So remember that not only papillary carcinomas, but also Hürthle cell carcinomas are ones that go to lymph nodes. All right. So you might think, but this is a follicular carcinoma. Yes, but it's that Hürthle variant. And so those more frequently have lymph node metastases. What about this thing?
I mean, it kind of looks like it used to be a lymph node at one point. I don't know. Like there's an edge where lymphoid tissue, but it's been completely replaced by follicular carcinoma. It looks necrotic, so Yeah. I mean,
So,
I guess I would consider this one a positive lymph node.
And do you see any viable cells?
I
Viable
mean,
tumor
here,
cells?
no,
Right? So
I do not.
what does this imply to you? With Hürthle cell neoplasms that are completely infarcted and we only see ghost cells, what does this imply to you? Future
Treatment effect?
cytopathologist.
Oh, Jesus Christ. Oh, it's been biopsied before, and like it's that's why it looks kind of funny.
Right. So right, I also see rapidly growing. So we'll talk about the difference between tumor necrosis from rapid growth and biopsy necrosis. And so this is biopsy necrosis. So this lymph node was FNA'd and it completely infarcted. And so Hürthle cell neoplasms are extremely sensitive to poking, and they often just completely infarct or partially infarct and leave like a rind of viable. And so that is quite particular to Hürthle cell things. So what makes me know that this was a post-biopsy infarction was, number one, I know that it was biopsy. We have a chart, we can ask, we can look. But if we don't know, if this is coming from an outside hospital and we have no information, what we do see is this rim of fibrosis, right? Fibrosis with histiocytes and giant cells, and maybe even hemosiderin. And so those findings of fibrosis with histiocytes and hemosiderin deposition, to me, is highly indicative of a physical procedural thing that caused this, rather than the tumor is so rapidly growing that it's necrosing. And we'll show you examples of true tumor necrosis in the next slides. Yeah, we can. It's 8:54. Yeah, I probably won't finish in the next 5 minutes, but certainly we can schedule another time. So who else has questions on this guy? All right, so I'm giving you more examples of more neoplasms. Maybe we can do this one next time, because I do want to show you, I think you can all guess what these answers are, but I do want to show you true tumor necrosis. There are empty lecture slots in December. Great. Fill them up, I'll take them. So here's a little nodule on the periphery that otherwise looks, I don't know, kind of bland. So maybe we'll ignore that thing. We're going to do a Krauss. We're going to look at everything else but the thing of interest. Here's the residual normal. All right. And here's the lesion. So this lesion is extremely, extremely cellular and even solid, right? Just wall to, when you have a vessel to a vessel, it's just wall to wall cells with only an occasional like colloid follicle in between, right? So this is solid, right? This is no longer trabeculae or cords. This is solid growth. We have solid growth. We have maybe some wrinkled nuclei. I can't tell if those are mitoses. Maybe there's one. Okay. We have solid growth. We maybe have mitoses. The nuclei are generally pretty round and regular. Maybe there's a little bit of clearing here and there, but really nothing like well developed for papillary nuclei. All right. And then where do I want to go? I want to go over here. So here's this grungy karyorectic debris with maybe ghost cells, and it is surrounded by just completely viable tumor, right? There's no like actual fibrosis. There's no histiocytes. It's just this grungy stromal material that's in communication with viable tumor cells, right? So to me, this is what you're saying of rapid growth necrosis. This is true tumor necrosis. And so I'm highly, 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 highly respectful of tumor necrosis in thyroid, because it often can mean something bad. So if you ever see true tumor necrosis, keep submitting, keep sampling. Here we see true tumor necrosis in the background of what is otherwise a quite solid and cellular neoplasm. So what are we thinking now? You always have to think of the next worst step. What's the next worst step here?
I feel like dedifferentiated.
Right, dedifferentiated or Tanner's writing poorly differentiated. Exactly. Here's another focus of true punctate tumor necrosis surrounded by viable cells, right? So whenever you make a diagnosis of carcinoma, you always have to think of what could be worse. And in this case, poorly differentiated. There's another punctate necrotic foci. So we can review the Turin criteria, or if you pull up my old lectures, you can see in the PowerPoints what the definition of the Turin criteria are for poorly diff. But basically, you have to have an invasive neoplasm. And let's, for the sake of argument, let's just call this invasion, even though maybe it's not perfect invasion on this slide. Overall, this tumor was invasive. And in fact, maybe this is actually a focus of angio invasion, where this like kind of triangular shaped plug is in a vessel lined by endothelium. You're welcome, Magna. So this might actually be a focus of angio invasion. So look carefully at these kind of plugs in vessels. But essentially, Turin criteria PDC, it has to be infiltrative. It has to have solid or trabecular growth. It has to have absence of PTC nuclei, and it has to have either increased mitosis or necrosis, right? So basically, we've met that here. So don't forget about poorly diff, because it sneaks up on you, and you might otherwise just call this some other follicular neoplasm if you don't remember to check off all of those boxes of criteria. So yes, this is poorly diff. It's 8:59. We can pause and resume at another session in December. But while we're on the topic, what I did want to show you one more thing just to confirm. Oh yeah, angio invasion. So this was a slide that I wanted to show you angio invasion on. You can see there's a plug, right? There's a plug that's like outside of the tumor nodule. So always go check out those plugs, whether they're foci of capsular invasion and they're sitting on the opposite side of the capsule, or whether they're truly in a vessel. And so you can see here that in order to define angio invasion, right, vascular invasion, not lymphatic invasion. Lymphatics are tiny, small, little vessels. Blood vessels are usually larger, kind of venous caliber vessels with occasionally muscular walls, as you can see here. Certainly thin walls, lined by endothelium, in which the tumor in it is also lined by endothelium, right? And the tumor in it also has either some kind of thrombosis attached to it or fibrous adherence to the vascular wall. And arguably, this looks like it's kind of stuck. It's like there's these fibrous bands here that make it adherent to this vascular wall. So I would call this, right here, I would call this angio invasion, okay? So that was the last thing I wanted to point out for angio invasion on this slide. So yeah, so we can stop and, oh, before you guys go,